to the Zoom academic meeting of the Department of Pediatric Surgery in East London, South Africa. Today, we are presenting this lecture webinar in association with Global Initiative for Children's Surgery, GICS, as a part of ENT webinar. And the topic is an approach to pediatric laryngotracheal obstruction. And the lecturers and the speakers will be Professor Shazia Peer and Dr. Barnor. So Professor Peer is Associate Professor and Head of the Pediatric Ear, Nose, Throat Department, Otolaryngology at Red Cross War Memorial Children's Hospital in Cape Town in South Africa. And she's also affiliated with the University of Cape Town. She did a 2-year pediatric ENT fellowship at Sick Kids Hospital in Toronto. She has formed a pediatric reconstructive airway surgery team, which she will talk about. She is the program director of the first pediatric ENT fellowship in Sub-Saharan Africa. She is also the chair of PENT Africa, which is the Pediatric ENT Society in Africa, and founder of Center for Advanced Pediatric ENT. And she's an advocate for ENT-related conditions affecting African children. And Dr. Barnor is a pediatric ENT fellow at the University of Cape Town Red Cross Children's Hospital. He's almost finishing his fellowship. He is a basically ENT specialist from Ghana. He is a fellow of the Ghana College of Surgeons, a part-time lecturer at the School of Medical Sciences in Kumasi in Ghana, and his current research focuses on parent-reported outcomes in children with symptomatic laryngomalacia who have undergone supraglottoplasty. So Shazia and Isaac, welcome. I will stop sharing. You can start sharing and deliver your talk. Thank you.
Can you see our screen there, Milind?
Yes, we can.
Okay. Well, good afternoon, everybody. And once again, thank you very much for this opportunity to speak. I'm very grateful that many people have shown up, and it's a multi-disciplinary discussion today. So please enjoy. I'm here with Isaac, and so I will first do a little bit of the introduction into the topic, and he will follow on with some specific conditions. So without further ado, I have no disclosures apart from the ones on the screen. And I specifically want to thank Milind for the opportunity to speak today, and to also all the PENT Africa colleagues who've joined. A shout out to you, and in particular the Global Initiative for Children's Surgery team. I think it's wonderful that we can actually have a webinar that crosses surgical disciplines. So thank you all for this opportunity. As you know, I'm based at Red Cross Children's Hospital, and we're the first largest standalone functional hospital for child healthcare in Southern Africa. It is affiliated to the University of Cape Town, and we get referrals from all over Africa, as well as, across different sectors like the private sector and nationally. So just to give you a basic idea about pediatric airways, and even though you all are specialists, I thought we'd just start at the very beginning. What do we already know about the airway? Well, the airway is either upper and lower. And as you know, at the top, that exists from the nasal ala right at the top, which extends into the nose and the back of the nose, and then unites with the oropharynx, which comes from the oral cavity. And that further then unites into the hypopharynx, which is the back of the upper airway, that then becomes the upper esophageal inlet. The airway is then limited by the epiglottis, and that's the laryngeal inlet, which extends into the trachea. And then the lower airways is managed typically by the pulmonologists, or even by the cardiothoracics, which involves the bronchi, the bronchioles, and those that further subdivide into alveoli. What we always want to put a shout out to is the children are not just small adults. And for those of us who start in the adult world and progress to subspecializing in children, a lot of our general colleagues always say, oh, just treat them like as small adults. And this certainly isn't the case. What we do know is that the bodies grow, the anatomy changes, and there's developing physiology. And a lot of the diseases, they're variable, and they occur as early as in utero. And what I've noticed, and in many cases, many people notice, is that the syndromes or those inborn errors may not manifest immediately. They may take a few months or even a few years to show themselves. This is a good schematic diagram of the adult airway and how it relates to the child airway. And if you just look at that side view, from the very beginning, you can see actually that the child's airway has a funnel inlet. And the funnel inlet is what gives you this perception of a wide opening that actually then narrows down. It's a high anterior larynx. And we always mention this in the premature kids or in the very small children. You actually have to really bend that laryngoscope very high in order to see it. The cricoid is the narrowest. Although with very swollen true vocal cords, you may also get glottic stenosis. And we know that the trachea is very flexible in children. This is a view of the laryngeal inlet. And for those of you who've done a few intubations in adults, you can see on the left, there's a very big opening and the vocal cord makes majority of the inlet. If you look in a child, you've got already supraglottic or area above the glottis, much more crowded and much more floppy, a short curled epiglottis sometimes, short area epiglottic folds. And the very obvious contrast is this bulky arytenoid tissue with short vocal cords in relation to that posterior arytenoid area. And so swelling can sometimes manifest much more dramatically. This is another schematic diagram of a trachea, and you can see from the child at birth to 2 years, the trachea is only 5.4 centimeters. And, you know, as one grows, the trachea will lengthen, extend, and also widen. And so one wants to bear that in mind, especially for those of us who do tracheostomies in neonates, and to bear in mind that, you know, there isn't much to carina in length. This is a very, very important thing to note. And airway resistance in children is actually much more dramatic. Children tank much faster than adults. And one of the reasons is because the airway and edema of the airway results in dramatic decrease in the cross-sectional area. So if you just take 1 millimeter shown in this picture, you can just see how dramatic it is, and take that with some viscous mucus, with difficulty expelling air and mucus and clearance and coughing, you've got much higher laminar flow and you've got such increase, 32 times increase in turbulent flow. When we look at pediatric airway, we always consider 3 different functions. And the big cog is breathing, and then there's swallowing and phonation. And the reason why it's like this is you have to be able to breathe to be able to swallow and talk. Breathing is the first and most important function, followed by swallowing and phonation. With breathing, they manifest with symptoms like stertor, noises around the nose and area above the larynx, and then stridor, which is laryngeal, tracheal, and so on. The swallowing, they manifest with dysphagia, so difficulty swallowing, and aspiration, laryngeal penetration. And then with phonation, it's really dysphonia. And when one looks at specifically the swallowing and the phonation, is it secondary upper airway obstruction? So for example, a cleft is a secondary upper airway obstruction, things that give you obstruction only because they're trying to swallow or feed. Questions to ask when you're taking a history specifically is the nature of the noises. You know, is it inspiratory, expiratory? Is it happening only when sleeping or feeding, eating, exertion, and or at baseline? And then with regards to your aspiration, is there dysphagia with aspiration? Is it continuous? Is there VPI, which is velopharyngeal insufficiency of milk coming up the back of the nose? And then we talk about difficulty feeding, choking, coughing, reflux, etc. The dysphonia is relevant for whether it's intermittent, meaning it comes and goes, for example, with a chronic cough or a cleft, or if it's persistent in terms of like laryngeal papillomatosis, something like that. Common conditions, common in the world, 60% is laryngomalacia, and the rest decreases down the pathway. But certainly in our population, in developing world centers and all across Africa, papilloma is still very high, up with 30 to 40%. We found this to be a very good picture just to describe the tracheal obstruction. And as we know, tracheal obstruction could be in the lumen itself, or along the wall, or in the wall itself, or outside the wall. And so luminal, mural, or extrinsic can present with this pathology, and they all will have airway obstruction. To bear in mind that it's more helpful to know what the pathology is before going in, but sometimes that's not always possible. Just in the interest of time, we won't be talking about foreign body, although in different parts of Africa, different people manage these cases. Certainly for us, the ENT would manage all of Africa, but in South Africa, cardiothoracics usually manage these. And then we'll not be talking about tracheoesophageal fastidios because that specifically is for the GI surgeons and the pediatric surgeons, but we try and focus on the others. So when we look at pathology based on age, we can see that in the neonatal in the neonatal age group, these are the pathologies. Once you get to 2 to 3 months, you get the congenital conditions as well as acquired conditions. So this acquired condition in this case would be something that is done to fix a child or that's instrumented. Foreign bodies and croup exist in infants. And then in young adults, it's a cause and effect. So infection, trauma, things like that. This is a really important graph to contextualize when you look at airway disease in the context of age. So in a child 0 to 3 months, they'll have a congenital airway disease. But in the premature group, because we're trying to keep them alive through intubation, that's usually the cause of the airway disease. An exit, for those of you who don't know, is an ex utero intrapartum treatment. It's an entire program aimed at alleviating an obstruction before the child takes the first breath, which may compromise breathing. This is a child with chaos, congenital high airway obstruction syndrome. And this is when delivered. We did an exit on this child, delivered intubated, half delivered intubated, then fully delivered. The size of that lesion was bigger than some of the kids in the next incubator, so about 600-700 kgs. 600-700 grams, sorry. And then an OOPS is an operation of placental support. This is with complete atresia and conditions like that. The mum works as a heart-lung machine, and the baby is delivered on the thighs. So how do we evaluate pediatric airways? Well, we want to obviously start with a good history and examination. We want to obviously exclude anything that's congenital and make sure that we understand where the noises are coming from, what the degree of failure is or respiratory effort. And then we always, in our context, want to do an awake, flexible fiber optic nasoendolaryngoscopy if possible. That's a flexible scope down the nose and both sides to exclude choanal atresia and to have a good assessment while the child is awake. If we need more information or we think it's necessary to intervene, we do a direct laryngotracheal bronchoscopy. You may have heard of a DLTB for those of you who've been to Red Cross. And then if it's something functional, but physiologically disease, then we always want a flexible bronchoscopy with a pulmonologist. And so the clues that we always want to take note of is lesions, masses, anomalies, any recurrent conditions. So recurrent croup, chronic croup, they're wet all the time, and then failure to thrive. If we're only worried about the airway, we're not concerned about anything else. We usually would, for example, do a DLTB. This is seen with kids with papillomas or subglottic stenosis, tracheal stenosis. And then if there's any doubt of any feeding issues, if the child is old enough, a barium swallow, a milk scan to exclude reflux, and where indicated, an esophagoscopy or a triple scope. Airway surgery actually has evolved over the years, so we don't use the candle and light method. But what we do have now are the Hopkins rods, and they're really sophisticated. They're many sizes. And we've even evolved to the video laryngoscopies, where anybody at the bedside can basically record a video of the airway and send it to us, or even manage further. Drugs and anesthesia and the perioperative care has also changed over time. So for those of you who've managed to walk into an ENT or an ENT surgeon doing a suspension microlaryngoscopy, this is what you will see. The airway is suspended on a Mayo table, and on the left, you can see that. On the right, you can see a tracheostomy in the child, and this is bypassing a very, very bad obstruction, which is laryngeal papillomatosis in the airway. On the left, you will note that we always want to see the anesthetic machine. We always want to see the SATs, and we ourselves want to be monitoring that because the patient is being ventilated. So even though they're asleep, they're breathing spontaneously. So this is just a Hopkins rod. It's a very, very tiny one. It's a 2.7 millimeter telescope that we use to railroad a small ET tube in the event that we need to rescue and intubate. There's quite a difference between this and the ventilating bronchoscope at the bottom, which helps to ventilate, providing oxygen. At the top, that's really just to intubate, so you want to pre-oxygenate. This is a video of one of my registrars from many moons ago, and he's looking at a patient with just treated TB, and you can see that we get a very, very good view of the airway just like that, and that's just a couple seconds. Other investigations, for example, CT imaging, you can see tracheal stenosis there. In children who are unstable, where they can't be extubated, they can't go for an anesthetic to have the tube taken out, they can't go down to CT scan, we can do a fluoroscopic tracheal assessment showing tracheal stenosis. And so how do we manage these kids? At Red Cross, we certainly do a lot of laryngoscopies, and these are, sort of the elective ones, but we also have emergent ones that we do at a regular basis. Most of them are with laryngotracheal stenosis. We also see papillomatosis. We'll continue to see it because the rollout program for HPV vaccination prevention is not adequate for the strains that we see. And then we also see other diseases as well, like bilateral vocal cord palsy, etc. When we decide to take someone to theatre, we discuss it with the anesthetic team, and intraoperatively, before we start, we want to know, do you have a plan A, B, C? What's the endpoint? We always communicate, even though it's very hard because they are our in-laws. We always try our best to keep an open communication. We adapt if anything has changed because the airways are always unpredictable. And we discuss from the beginning what's going to happen at the end. Are we doing definitive surgery? Are we just going to intubate? Are we going to stage a disease? And then post-operatively, where's this child going? To the ward, to ICU? Are we going to have them breathing spontaneously? Are they going to wake up? And these are important questions because you want to know that, you're not going to do harm. This is a combined airway assessment with one of my colleagues, former colleagues, Fiona Kritzinger, doing a flexible bronchoscopy. And why is it good to do a combined airway assessment is because you have physiology, dynamic movements with the flexible, like tracheomalacia. With the rigid, you can assess the vocal cords, you can assess the cricoretinoid joints, you can size the airway, and you can intervene if you need to. Sometimes we do a triple scope with some of our colleagues in private, and that's an esophagoscopy, and we're able to get much more information in that regard. Everybody is present at the same time, and decisions can also be made. So airway conditions are challenging. What you do now can have lifelong implications. And really, it's not about doing nothing or doing no harm, but it's about doing less harm now than if you were going to do nothing at all. So any surgical intervention at whatever level of upper airway, even if it's taking a tonsil and an adenoid out for obstructive sleep apnea, must aim to improve function. So all of these things have to work to one goal. For example, this was a child who was born with a huge neck mass, not planned for exit, but came out and deteriorated rapidly. All we needed to do was establish a safe airway. We took this child to theatre, debulked and excised most of this mass. It was a teratoma. The child did fine. On the right, we have a child with a large head and neck mass that was extending into the brain. We intubated and discussed this as a very aggressive teratoma, which is considered malignant, and opted for oncology to take over and not to do a tracheostomy or anything like that. So sometimes just establishing an airway is all we need to decide on what to do next. So the treatment is one, like we mentioned before, optimized breathing. So this will alleviate the obstruction, and sometimes OSAS. It also will optimize breathing if you've got a compressive head and neck mass and if there's stenosis within the airway. You want to improve quality, so releasing webs and removing anything on the cords like papillomas. And to address aspiration once confirmed, a laryngeal cleft repair, cleft palate repair, and doing anything like that would be helpful. The main thing really is if you want to fix the airway and you can't, you can do a tracheostomy. If you need a PEG, you may need that to protect the airway, to avoid a tracheostomy, or you may need both in some cases with complex children. We do know they're vulnerable, and we always want to consider the parent and the home environment as much as the child. Early treatment may be an option, or we may opt to just wait it out with a tracheostomy. We always worry about complications doing things early and about the implications for development and growth. So we want to pretty much get a tracheostomy out and definitively cared pathology by the time they get to school. We want to start a speaking valve and speaking early on so they can get socialization and speech and language acquisition. A tracheostomy for upper airway obstruction is there to alleviate an obstruction. It's either temporary or definitive, but it's not there for tracheal disease. It's really for laryngeal or upper airway, and it does provide laryngeal rest and bypass the obstruction. So thank you very much. I'm going to hand over to Isaac, who's going to do the fun part, which is all the specific conditions. Go for it.
Thank you, Prof. So I'll be looking at some of the specific conditions that lead to laryngotracheal obstruction in children. I've already been introduced earlier, so I'm not going to talk much on this slide. So I'm actually from Ghana, from a hospital called St. Peter's Hospital. All I just want to say is that ENT is a very young discipline in Ghana with a population of 32 million. we only have less than 100 ENT surgeons. So we'll first of all start with laryngomalacia. Laryngomalacia is the most common congenital laryngeal anomaly we see, and it's characterized by the inward collapse of the supraglottic structures on inspiration. 80% of children with laryngomalacia also experience what we call gastroesophageal reflux disease. And this stridor or airway obstruction is exacerbated by things like crying, agitation, feeding, or placing the child in a supine position. The good thing about laryngomalacia is that most of it, about 90% of them, are self-limiting, resolving in just about 12 to 24 months. But some severe cases, which are characterized by stridor, failure to thrive, and OSAS, will then go on to need or require surgical intervention, which is either a supraglottoplasty or a tracheostomy. So the management of laryngomalacia, as I already said, is individualized. So it depends on the level or the type of laryngomalacia that the child has. So we have the conservative and then the surgical. Under the conservative, we can do active observation where we do regular follow-ups until it resolves. As we also monitor the central growth charts. We also give medical therapy such as the PPIs or the A2 antagonists, because remember, I told you that it's associated with a lot of gastroesophageal reflux disease. And then the speech and language therapists also help in the management. And then we also teach position adjustment. What are the indications for this surgery? As I said, about 10% may require surgery. And if the diagnosis is confirmed on the DLTB, which is the direct laryngotracheal bronchoscopy, or if the child is not responding to the anti-reflux treatment, or they are developing the signs of the severe laryngomalacia, then we have to go in to do a supraglottoplasty. So as we can see on this video, this is a patient who has laryngomalacia. I can see from the curled epiglottis, the shortened AE folds, and then the flapping in of the arytenoids as the patient inspirates. So we always have excellent results, close to about 98% of resolution when children undergo supraglottoplasty. So as you can see on the image on the right, see how on the left, the epiglottis is all curled up. Arytenoids are pushing in there, totally occluding the glottis or the laryngeal inlet. But on the right side, following the supraglottoplasty, you can see how everything opens up nicely. As I said, laryngomalacia is associated with a lot of reflux disease. So we need to, these two are closely related. And if untreated, this gastroesophageal reflux disease often worsen their symptoms and may also delay wound healing following the supraglottoplasties. So we'll quickly look at recurrent papillomatosis. As Prof said, is something that we see is one of the common causes of laryngeal airway obstruction we see. And as we can see, this papillomatous lesions completely occlude the airway or the larynx in this patient. So you see all these vegetations completely occluding the airway. This is also another. So in some of the children, unfortunately, we develop papillomas down the trachea, which is an extensive airway disease. But we found out that if we are to advocate for the prevention of the HPV prevention programs to expand their nets to cover the subtypes 6 and 11, which are usually the types implicated in the papillomas, it goes a long way to actually relieve children of this, especially children in Africa, of these papillomatous lesions. So let's quickly look at laryngeal clefts, which are also very, very important, and some of the common causes of secondary airway obstruction we see. And this is associated with an abnormal communication between the larynx, or between the airway and then the GI tract. So there's a defect in the party wall. And this is a very rare condition. As you can see, 1 to about 20,000, but they are actually things that we see. And it's characterized mainly by the dysphagias, difficult swallowing, choking, aspiration. And such children always come in with recurrent chest infections and chronic cough at night. treatment is usually of two types. We have the medical and then the surgical. But the medical and the surgical, before you choose the type of treatment, depends on then the type of the cleft. We have 4 major types of clefts from type 1 to 4. The type 1 and type 2 are usually, the defect is usually above the cricoid, and then the type 3 and 4 are usually below, but the type 4 is usually within the mediastinum. So the type 1 is actually mostly treated conservatively by using the PPIs, the antibiotics, and then the modified feeds. We watch the growth curve, but then if there are recurrent admissions, if it's cough at night, or the patient is still experiencing bad signs of dysphagia, which is affecting the growth, then we opt for a closure or surgical intervention. So the surgical intervention could be done either endoscopically or with an open approach or a combination. So depending on the type of cleft, we choose what type of surgical option to go for. Sometimes to also reduce the reflux, the children undergo a PEG, which is a percutaneous gastrostomy, which may or may not be associated with a fundoplication. All these are aimed at reducing the reflux, and sometimes we do this in Red Cross as a way of optimizing the children before surgery, definitive surgery is carried out. So as you can see from these images, this is on the left, this is a child with a type 1 cleft who was having a lot of laryngeal and feeding issues. So was taken to theater where the cleft was closed, and then on the right you see the post-op outcome. So for some of our airway surgeries post-op, we use this combination we call Silodex or Ciprodex, which is a combination of ciprofloxacin with dexamethasone, and this helps us to actually avoid scarring, to aid in the healing, and also to prevent the formation of biofilms. And then we also give our PPIs and steroids as part of our post-op care. So let's quickly look at congenital glottic subglottic stenosis, which is also something common that we also see here. And this is due to an abnormality in the embryogenic period. In this period, there's failure of complete recanalization of the primitive larynx, and this involves a spectrum of laryngeal anomalies. As you already see, this is glottis subglottic. So from the video you see down, so this is a child with a laryngeal cleft, a type 4, a laryngeal web, sorry, which is associated with a subglottic involvement, as we see in the type 3 and then the type 4. But we'll be focusing mainly on the stenosis, not the webs. So the congenital stenosis could be membranous or cartilaginous. The membranous ones are usually soft and can easily be popped even during the intubation, so most of them can even go unnoticed. But the cartilaginous ones involves the framework, that is the cricoid framework, and this usually needs some form of surgical intervention to fix. So the acquired subglottic stenosis, as I said, so subglottic stenosis could be congenital, acquired, or could be mixed. But so let's quickly look at the acquired. So the acquired before the 1970s, as a result of poor neonatal intensive care practices, poor intubation, and little knowledge on the effects of poor intubation, there was increased prevalence of acquired subglottic stenosis. But currently, we're just looking at incidence of about 0 to 2% as a result of changing these habits. We're now using appropriate tube sizes of the neonates based on the weight and age, and we're allowing some air leak around the 80 tubes. So these are all reducing the incidences of the acquired subglottic stenosis. The pathophysiology generally involves inflammation as a result of maybe using a bigger tube or inflating the cuff. It leads to damage of the mucosa. That leads to inflammation, swelling, and all that. Sometimes there can be exposed cartilage. And then in the healing process, there's fibrous proliferation, and then remodeling that leads to the subglottic stenosis or even cyst formation, which also leads to a lot of obstruction. The image you see here, you can actually see a huge cyst in the subglottic space, which is also obstructing the airway. And in this case, we do deroofing of the cyst, and then sometimes with associated dilatation, to actually open up the subglottic space. So what are some of the risk factors for subglottic stenosis? We decided to stress on this so that all of us will be mindful of this. So the increased, the number one risk factor, as we see, is the intubation injury. Every 5 extra days of intubating a child increases the risk by 50.3%, which is quite significant. So premature children, children who have meconium aspiration, children who have had inhalational injuries from burns, and those having gastroesophageal reflux disease or have an increased risk of developing or subglottic stenosis or tube injury. And then there are these 2 papers that shows that under sedation is also a serious risk factor. So in our various practices, we should ensure that when children are intubated in the ICU, they should be sedated and sedated well, so that there's little movement that leads to injuries in the airway, leading eventually to the stenosis to both the larynx and then the trachea. And then there's also a study done which also showed the association between the length of intubation and then the formation of subglottic stenosis in children. So this is something which really occurs. So as you can see on the left, this is a child who was intubated for just 5 days following a burn. You can see the exposed cartilage and all that as a result of tube injury. And then on the right, as the video progresses, you can see this posterior glottic band. And then we can also see the subglottic cysts, which all occurred as a result of intubation. So subglottic stenosis is actually staged using the Mayer-Cotton system, and we have 4 grades, grade 1 to 4. Grade 1 from no obstruction to about 50% obstruction, and grade 4 where there's no detectable lumen. So how do we manage subglottic stenosis? It's to manage it, you depend on the disease factors, as in the stage of the disease. Is it congenital, is it acquired, is it membranous, is it framework? The surgical scale, that is the scale of the surgeons, and then the center, if there's a center available to also carry out this task. And then patient factors are also looked at. The simplest way of treating the subglottic stenosis, which is actually the mainstay in many of the centers, as we see in lower middle income countries, is tracheostomy. Because, I mean, that is the safest, because you are bypassing the pathology, you are allowing time for the child to maybe probably outgrow the condition. And then it's the safest and simplest solution. But we should be mindful of the morbidities and complications which are associated with tracheostomies. So as I said, the management of subglottic stenosis could be it's mainly surgical. We have could be an endoscopic or open airway approach, or a combination of both. So the endoscopic involves incising or cutting the obstruction, the cricoid, and ballooning it. In some centers, they see this as even the only way of repairing subglottic stenosis. Or we can do the open airway, where we actually open up, put in a graft, and then or a stent, and then later on take out the stent. But then in like the grade 4s, you can also do a complete resection, which is a cricotracheal resection with a laryngotracheal anastomosis. And then sometimes we do the combined. But then these are not mutually exclusive choices. One always complements the other. Luckily, we are in an age where we've made a lot of advancements in endolaryngea surgeries. Now we have balloon dilators, the suspension laryngoscopes, we have the stents, we have the debriders, coagulants, lasers, and these have all improved endoscopic laryngeal surgeries. So as you see from this image, on the left is a subglottic narrowing. As you can clearly see, this is about a grade 3. And then in the middle, from that short video, this was a balloon dilatation. And this balloon luckily is locally produced and was invented by one of our own, Professor Dalenluba from the University of Cape Town. And this is a non-occlusive balloon, so as you dilate, the airway is not obstructed, so the child can still be receiving ventilation as the dilation goes on. And on the right, post-dilation, you can see how wide the subglottic space is looking now. The other surgical option available to us when it comes to subglottic stenosis is laryngotracheal reconstruction or open airway surgeries. And these are aimed at expanding the cartilaginous framework. So you can either do an anterior split or and then put in a cartilage, a costal cartilage or a thyroid ala, or do an anterior and posterior depending on how narrow the airway is. This can be done as a single stage or a double stage. So these are images showing how it is done. So there's the anterior split, and then the posterior is also split, and then the grafts are placed, and we see that it widens. So as you can see, this is a patient that we did. So the graft is harvested, and then it is shaped, and then it is used in the widening or the repair. So in summary, the management of subglottic stenosis encompasses a variety of options, and these are not mutually exclusive of each other. The decision-making is always key. We must know when, what, and how to do it. And the correct or the right patient selection must be always advocated. And always refer such cases to specialized centers for revision or advanced surgeries. So we'll quickly look at tracheal stenosis, which is also one of the important things we're looking at now, and this involves narrowing of the trachea. And as Prof started off earlier, this could be luminal, or it could be extrinsic, or we could have something compressing the trachea from the outside, which is an example being the vascular rings. These could also be congenital or acquired. The acquired ones, as I've already stated, are usually due to intubation injury or trauma from a tracheostomy. So how do they present? They present with either airway symptoms or non-airway symptoms. So stridor, difficulty in breathing, and this stridor is characteristic, has this washing machine quality. It's a biphasic type of stridor. They have a stridor at baseline or on exertion, persistent cough, recurrent infections, and they always experience acute life-threatening events. And then some of the non-airway symptoms include difficulty in feeding or failure to thrive. So how do we evaluate children with tracheal stenosis? So obviously a good history and clinical examination is very important. We do our flexible nasal endoscopies in the OPD, also to rule out other laryngeal pathologies that may coexist. And imaging is also very good. Even a simple X-ray, if you are in a center that you don't have easy access to a CT or even an MRI, even just a chest X-ray or neck X-ray is enough for you to even capture a narrowing of the airway. And then the DLTB and the SML, which is a suspension microlaryngoscopy, it's always the gold standard, also helps us to actually identify and actually cite. And then the CT scan, we can also have a 3D reconstruction, and this helps in surgical planning. And then if there are any feeding issues, we can also conduct a barium swallow or neck swallow or atmosphagroscopy. So one of the treatments available for long segment tracheal stenosis is a slide tracheoplasty. As you can see from the images, it's a surgical procedure done to actually widen the diameter or the lumen. But in doing so, you end up also reducing the length of the trachea by half. That is actually very good in widening the lumen. And it also has fewer complications. The blood supply is preserved, and then there's a short intubation period, and there's also healthy tracheal growth. So as you can see from the images, this is a 6-month-old who had a complete rings and hypoplastic ground in the pulmonary artery sling. So we see the complete rings as we go down the video. You can see the complete rings. You know, the trachea should have a horseshoe or the C-shaped rings, but these are complete O-rings. Then this is the slide intra-op endoscopic view. As you can see, the trachea opened up. And then this is post-operative surveillance scope 2 years after. You can see how wide the tracheal lumen is looking now. For the sake of time, I won't be able to show most of the full extent of the videos. Some short segment tracheal stenosis can also be treated with resection and end-to-end anastomosis. So as you can see, this is one of the anastomotic parts, very thick anastomosis about a grade 4. And grade 4 and 5. And this sweet girl we're seeing here, the child with myasthenia gravis, who developed tube injury as a result of prolonged intubation, developed tracheal stenosis, so had end-to-end anastomosis. And luckily also regained her,
Guillain-Barré.
Guillain-Barré syndrome, and luckily also regained her ability to walk. Severe tracheomalacia is also something that we also encounter. It's also one of the leading causes of laryngotracheal obstruction. And this is one of the dynamic airway obstructions, as you can see, as a result of the whole trachea seems to be obstructed as a result of this weakness in the tracheal wall. And they are usually characterized by children have failure to thrive. Sometimes they need BiPAP at night and all day when sick, and they have acute life-threatening events. And we had such a case in a 9-month-old, and it was discussed with our airway reconstruction team, and a posterior tracheopexy was performed. So tracheopexy is one of the surgeries performed to actually correct tracheomalacia, where the anterior wall is actually suspended to the posterior wall of the sternum to keep the airway open. So this is so tracheopexy was ongoing, and then 7 days post-op, you can see how well the tracheal lumen is opened up. So we are not seeing the collapse as we saw in the previous images. So we'll quickly look at some head and neck conditions that also cause laryngotracheal obstruction. And these are also categorized into congenital, developmental, infectious, or inflammatory, or neoplastic. And 90% of all head and neck masses are found to be benign, with a list down there showing the commonest malignancies we see in children, usually the lymphomas and the nasopharyngeal carcinomas. So this is a list of the congenital, the inflammatory, and the neoplastic masses as we see in the head and neck region. So clinical workup will also include a comprehensive history, good examination, a flexible nasal endoscopy. As ENT surgeons, we don't go anywhere without endoscopies. So the imaging involves the chest X-ray, the chest X-rays to rule out any suspected TB lymphadenopathies. We can have the ultrasound, CT with IV contrast, or the MRIs. And as we can see, the pros and cons, or the advantages and disadvantages of using the ultrasound, the CT, and the MRI. But MRI offers a superior contrast resolution in evaluating masses, and when it comes to vascular lesions, have been found to be the gold standard. As surgeons, we all know the benign characteristics and the malignant characteristics of head and neck masses, so I'm not going to do much on that. Investigations will include the following laboratory investigations, which is a full blood count, and then we can also do fine needle aspirate for cytology and also for microbiology culture and sensitivity. So I'll quickly look at some specific ones. These are mainly images, and then so we have one which is a circular cyst. As you can see, this a cyst which emanates from the circle of the larynx. And from the video you are seeing, this is huge cyst, which is completely including the laryngeal inlet. And this is treated by excision or drainage or muscularization. And then we have the bronchial anomalies, which are also, especially the cystic types, can also lead to loss of laryngotracheal obstruction. The type 2s, we have the pit in the tonsillar bed. The type 3s have their pits in the piriform fossa. So these are images showing some of the bronchial sinus with a cyst, and then I'll show on this video, if you look closely, you can see some fluid squirting from the tonsillar fossa, and that is from the pit of the type 2. So other congenital masses, bronchial, dermoid cysts, teratomas, these are all masses that can really obstruct the airway. And then we have the congenital thymic masses, which can also obstruct the airway. Now, this component was cleared from the anterior mediastinum, and mediastinal mass always compress the airway, especially in children. Thymopharyngeal duct cyst. This was found in a 6-week-old girl who was otherwise healthy, but always experiences acute stridor when breastfeeding, and this is followed by rapid neck swelling. So this was also excised successfully. And then lymphatic malformations are also one of the commonest things that we see here, also causing a lot of airway obstruction. As you can hear in this chart, you can actually see how it's really obstructing the airway of this 3-year-old girl. Had to use BiPAP at home, but was started on sirolimus with fantastic results. So on top, before the sirolimus was given, this is a sleep study. You could actually see the dips in the oxygen saturation, and then the mass very large on the MRI. But on the bottom post-dose of the sirolimus, we can see how the sleep study is improved. There are no major dips. And then the mass seems to have also resolved nicely. A bronchogenic cyst is also one of the cysts, the head and neck cysts that we also see, which also compresses the airway. And yeah, so for lack of time, we are not going to show a lot of images. So I'll invite Prof Pierre back in to summarize and then end the presentation for us.
Thanks very much, Isaac. So it's a big cohort of patients. Unfortunately, we can't take up all the time, but that was great. That was lovely. I mean, he went through a lot of the pathology that we manage and that can be managed. So just to summarize, just in a second, really, or a few seconds, it's always challenging, these airway obstructions. We do need to enlist a group of people, and our endoscopic and open management is complementary, but we do need an aerodigestive team if it involves dysphagia and aspiration and so on. We always here very fortunate to have an excellent PICU anesthesia team and surgical specialties. We don't know what it's like everywhere else. And so for us, we always advocate for best outcomes in few high volume centers with good referral pathways and that have training programs that we're fortunate enough to have at Red Cross. So thank you very much. I just want to put a shout out for our summit that's in November. And then you just give it back to you, Milind.
Yes, Shazia and Isaac, wonderful, really very, very interesting. Your videos are superb quality and they were very illustrative. So I don't know if there are any ENT surgeon specialists in the audience. I and Dr. Peer can identify Dr. Suraj Gaire, who is the registrar in ENT from East London. So Suraj, do you want to ask any question or want to make a comment? Have you seen any of these pathologies in East London?
Thank you, Dr. Shidneys. And hi, Prof Pierre. Hi, Isaac. How's it? Sorry, my camera is off. I can turn it on there if you want to see my face, but it hasn't improved much since I last was there. Thank you very much for the presentation. It was an excellent presentation, as it does. I like the overview of everything, the brief little overviews of everything, and from my side, I thought it was a very good presentation, especially for people who aren't ENT, just to get a bit of an idea of the way that we sort of manage them and how we should work up towards these patients. Yeah, I don't have any other comments to make except for thank you very much, and good to see you guys again.
Thanks,
Nice
Suraj.
to know you there.
Yes, thank you, Suraj. Then I'll just ask our three consultants to comment one after the other. Dr. Nakolo Mashawawe is our junior consultant. So Knox, any comments, any questions for Prof. Peer?
Good evening, and thank you so much for the wonderful and informative presentation. Just out of curiosity, in regards to subglottic stenosis after balloon dilatation, what are the re-stenosis rates post the dilatation? And do you need to maybe infiltrate like steroids or any anti-inflammatories post the dilatation just to reduce the recurrence rates?
I was going to say I can ask Isaac to answer, but I don't know if you want me to answer it. Okay. So it is a good question because it's a complex question. And the one thing that is difficult to answer, and I can tell you just from my own experience, is the subglottis it's a ring of cartilage. And so if you have subglottic stenosis and your cartilage is small, so if the ring of the cartilage is small, no steroids or no dilation is going to work. You have to cut it open. So you have to do an anterior cricoid split or an anterior and a posterior cricoid split, and you may have to put a spacer on an interposition graft. If your cartilage is of the correct size, but your lumen is just swollen, then you can dilate, and you can dilate twice, sometimes 3 times. If your lumen is not swollen or the swelling has gone down and has resulted in scar formation, fibrosis, then you can cut, you can do what we call it a Mercedes-Benz sign, and you can inject some steroids and you can dilate. But the expectation that the fibrous tissue has hardened and become more firm means that you're unlikely to get the best results. So again, you may need to open it and put in a spacer to give yourself an expansion. If you have acute edema, a child who comes in with croup, and you know that the airway is just swollen, how do you release a ring from your finger? You cut it open to release it so the swelling of your finger goes down. In the same way, in the acute setting, if you have luminal swelling that's so swollen that a tube even barely gets in there, then you have to crack that open, release it again, and do a split. And it allows the edema a passage out, and it can heal in a little bit more of an expanded way. So it's a bit of an unfortunate answer that I'm giving you so many answers, but it really does depend on what you start with.
Thank you so much.
You're
welcome. Knox, any more questions or comments?
No, Prof, thank you.
Thank you, Knox. I see Dr. Nilesh Tank is here, and Dr. Nilesh is a pediatric surgeon in Jodhpur, India. Nilesh, any experience? Do you work together with your ENT colleagues there?
Thank you, Dr. Chitnis. That was a really wonderful presentation from the speakers. The thing which I want to ask our speaker is, with the advancement in the antenatal diagnosis and the ultrasound machines, we do see a lot of patients of congenital high airway obstructions during the first and second trimester of the pregnancy. So, I mean, do the speakers have any experience of, seeing such patients during the antenatal period? And if they do see such patients, how do they prognosticate such babies in front of the parents?
It's very hard, because you're already past the trimester where you can abort. So you have to be very careful how you manage it with the parents. So we have a fetal assessment unit at Grooteskier, and we do fetal MRIs. And you need to assess, one, is the baby normal, and is it just a lesion in the neck that's obstructing? Or is the baby having is it a syndrome that may have more complications with time? If it is a chaos where you can see a lumen below and the lungs are growing normally, then you would measure it out and you would see how much of it is volume versus how much of it is soft tissue and fibrosis and things like that. Because when you do deliver and you think of resection, the last thing you want is third volume loss or fluid loss and things like that. So if it is that you can actually resect this, then you would deliver as an exit, so ex-uterine intrapartum, and you would do a partial delivery, intubate, and then release the baby from the placenta, cut the umbilical cord, and take the patient next door for surgery, or otherwise prepare in the next few days. It just depends on what that is, if it's a teratoma or if it's something more benign. So there are those options available, but counseling and preparation for both the patient, the parents of the patient, as well as the surgical team doing it, is extremely important, because you want to have, you want to know this is a good patient selection and a good parent, and that you can actually manage this child afterwards. So I think the fetal assessment unit is quite important with that, and having a good quality obstetrician who's invested in that. We have a multidisciplinary team where pediatric surgery, us, pulmonology, and even the obstetrician sits with the family and discusses it. And we only really discuss prognosis after the latest fetal scan, because things change, as the baby grows. But it's a difficult question because it's quite resource driven, and it can cost a lot. And, you have to know that if you deliver the baby, that you're not going to have any issues with the delivery. And when they are delivered, you got to know that that brain is normal before, because you don't want any issues with the brain And then when you decide on resection, you've got to have everything there. So I think it is quite important to have a good head and neck surgeon. We have Johan Fagan here. So for the ones that we've done, he's been involved. And one of the ones at Red Cross I did with Sharon Cox a long time ago, the one in the picture, one of those in the picture. And certainly if you have the skill set with surgeons, anything is possible. You can put this together with 4 people. You just need to have an invested radiologist and a good counselor for the parents. Good luck.
Okay, Nilesh, any
Thank
other
you.
question?
No, sir, no.
Thank
Okay.
you so much for joining us from so far.
We have our medical officers and some registrars. So any one of them wants to ask a question, because this is not a thing which we see or deal with. And that's the specific reason we wanted the specialist to talk about it. So any of our
Dr.
registrars-
Chidis, can I ask one question, please?
Yes,
It's
please.
Suraj.
No, please.
Can
Yeah.
I ask one question?
Yeah, sure.
So to Prof Peer and Isaac, I just want to ask about, we have one patient that came in recently and is known with JORP, has been to us a few times. Unfortunately, our cardiothoracic service here isn't excellent, but they are available if emergencies needed. But I wanted to just ask, because this patient had quite extensive papilloma, and the papilloma, when we took for DLTB and debulking for airway concerns, we found the papilloma going all the way down to the carina. And I just wanted to ask, what is your approach to papilloma that goes all the way down? Do you chase it all the way down to the bronchioles as far as we can see from the ENT side? Because I mean not bronchiole to the bronchus, because that's as far as we can go. Would you go all the way down? How would you generally manage it? And in that case, would you then just ask cardiothoracics to take over management? And what would you suggest?
It's very tricky because we don't really go beyond carina personally. If you have to, you can with a rigid. The main thing with papillomatosis that extends distally is to only pick the ones that are obstructing. So if you've got mural ones, or if you've got fronds extending from all over, they're going to all come back. You have to relieve the obstruction and what's happening beyond that, because they can get an obstructive picture and say they left main bronchus, and then the entire lung will collapse. So you want to relieve any complete obstruction. That's what you really want to do. And then just consider adjuvant therapy for patients like that, because the moment you start entering areas that are beyond our space, you can get injuries, you can get bleeding, and you can get death. So if it is something that's obstructive in a single space, you treat it like a foreign body and you remove it. But you wouldn't treat every single lesion. You'd start considering adjuvant therapy for those kids, because that already has converted them to a system. If you go to beyond your system, that's multi-system disease. So you can just Avastin.
Okay. Yeah, because from our side, we usually go just until the carina, and that's exactly what you said. That's where we stop. And just that our cardiothoracic services here weren't willing to go further and check further for us. So I just wanted to know. Yeah, we can do that, and that is actually our plan if the child has any more symptoms.
So if you can do a high resolution CT scan, you can tell at what point if there is an obstruction versus a cavitation or an abscess or something worse.
Right.
Yeah, sorry, good
luck. Thank you very much.
You're welcome.
Thanks for the presentation. Thanks, Isaac.
Milind, there is...
Sorry, go ahead.
No, I was just going to say, there is, Bilke de Hond is online, and I don't know if she wants to say anything. I know that we sometimes do something called triple scopes together. We share patients, and Angelo Valisoa is an ENT surgeon from, he's a current fellow, but he originates from Madagascar. If there's time, I don't know if either of them want to...
There is absolutely time. So maybe Bilke can comment or make a... is she there?
She wants.
Okay. Is she still there? Bilke, any comments from you? Any combined experience in private? Not sure whether she is able to hear us. Sorry, you can ask the other colleague to unmute and comment. Who is the other colleague?
Angelo Valisoa. Angelo?
Angelo, you can unmute yourself and make a comment.
Sorry to put you on the spot.
Good evening, everybody. Good evening. Hello, Prof. Peer. Hello, Isaac. Do you hear me?
Yeah,
Yes.
they can hear you.
Yeah. Thank you very much for that excellent presentation. It is very interesting as usual. Yeah. The management of that airway seems to be obvious, but it's very tricky and very difficult to manage for sure. It depends on the abstraction or the defect. But from our perspective, hand and neck surgery, we used to, for me personally, we used to excise something blocking or something like a huge mess. But dealing with an obstruction inside a very tiny area, very tricky anatomy, and unforgivable mistake can be made. And my question and maybe a remark is, when do you decide to hand over to the cardiothoracic, or keep on managing as an ENT surgeon with those kind of very difficult case of narrowing or a tracheal lesion? Yeah, back home we have cardiothoracic, and most of them deal with all of trachea lesion, particularly for tracheomalacia or tracheal stenosis. We don't have so much experience as an ENT to do an anastomosis or resection of trachea, even in on the cervical area. So my question is, at what point, particularly at the Red Cross, do you hand over to cardiothoracic team when it comes to deal with narrowing trachea or that kind of malformation?
I think it's a reasonable question, because I think we blur those lines quite a lot.
Yeah.
I think we often are the gatekeepers of acute airway obstruction, acute biphasic stridor, any deterioration in breathing. That's something that we've taken ownership of here. And I think that's why we sort of feel the need to be the entry point for patient patient care, and then with the help of pulmonology, cardiothoracics, general surgery, we then would either hand over the patient or transfer or do it together. We would manage endoluminal disease until carina, depending on the age of the patient.
Yeah.
If it's open airway, if it bypasses the thoracic inlet, they manage it. But because so many things are vague and uncertain when the patient comes in, we manage all airway obstruction until we give it up. Any mediastinal disease in that same light is managed by them. So thoracic inlet would be the division of the in-laws, so to speak. But we would manage the trachea together. Because there's only so few people in this hospital, so few people in the country, and so few people in Africa, we tend to pour over into other disciplines because there's so few of us, and that doubles the numbers. So I think it is a tricky question and probably unfair anywhere else, up north, unless you have cardiothoracics willing to come help you with a subglottic stenosis one day, you're willing to help them with a bronchial stenosis endoluminally. So I think that's the relationship that we've developed here for now. That's fair enough.
Okay. And maybe one more question or a remark. Have you ever experienced a papillomatosis, very extended papillomatosis, and you do have to consider palliation for the child?
We've got one in the ward now, actually.
Oh,
yeah,
really?
It's sad. We've lived with her for 6 years, and now she's got cavitations in her lungs, so she's needing, oxygen, home oxygen, which is not something we've ever, considered, because, we can fix the upper airway by debulking, like Suraj has said, but what do you do lower down? And what do you do if it's alveolar
Mhm.
So, yeah, so we always get it's a group of pediatricians called PEDS-PAL, palliative care. So the
Yeah.
child's not going to die tomorrow, but they're on a pathway of care that may be palliative or may not be active, basically. So we will stop her Avastin because she's got more complicated, and see where that takes us from supportive oxygen and supportive care. But it is very hard for us because we don't see it.
Okay. Thank you very much. Thank you again for that excellent presentation, Prof. Peer. Thank you, Isaac.
Yeah, Angela.
Thanks for your questions.
My question to you is, does papillomatosis not respond to antivirals?
No,
It
it doesn't.
Oh,
Yeah, it doesn't
okay.
respond.
Okay.
Yeah, I wish we had something that it could respond to, but there's now been a lot of the growth in the field of treatment, which is gene therapy and then biologics. But there are hundreds of thousands of dollars, like $200,000 for just 3 weeks. So we would never see that. So there isn't really any treatment for it. It's really sad.
Okay.
Yeah.
I have one question for Isaac. The posterior tracheoplasty, where do you suture the wall of the trachea? I just didn't gather it.
Yeah, is it a tracheopexy?
Yeah. So for the tracheomalacia, you
Yes, for the
advocated
tracheomalacia. Yeah, so they suture the anterior wall of the trachea.
The posterior wall of the trachea. It's a
No,
posterior
it's a
trachea.
posterior.
You asked me
posterior
the
tracheoplasty.
Posterior tracheopexy.
Yeah.
For the laryngeal.
Which one you
No,
asking
the
about?
posterior one. The posterior one. So where do you suture it?
Onto the anterior spinal ligament.
Oh, anterospinal ligament. Okay.
So you have to move the esophagus away.
Ah.
You basically release where the fistula would have been. You release all of that, mobilize the anterior spinal ligament, and then you put your stitches there.
Okay.
But you have to do a flexible bronch just to see exactly where the malacia is.
Yeah.
So you basically balloon it back.
Yeah. Understand. Okay.
It's done via thoracotomy.
Okay. I'll ask Dr. Selo Machaya, our senior pediatric surgical consultant. Selo, any comments?
Hi. Thanks, Shazia. Thanks, Isaac, for the talk. That posterior tracheoplex, that's what we also do for recurrent tracheoesophageal fistulas. Apparently, that's the in vogue thing now, instead of putting in tissues and everything in between. But the last time I was involved in tracheomalacia, we were doing more aortopexies than posterior tracheoplasty. So.
Yeah, so it depends if it's anterior intrusion, anterior compression, or posterior intrusion. So if it is posterior intrusion, you can do an anterior pexy, but you may not
very good.
resolve the tracheomalacia from the trachealis intruding. So you'll have to do something for the back wall. So it just depends where the intrusion is coming from, if it's posterior, anterior, or both.
So you can do either or both, depending on where the obstruction is.
Yeah, and depending on how severe the posterior component is. So the thing is, because the fistula is from the posterior component, you're robbing Peter to pay Paul. So you've got less cartilage, less tissue. So it naturally wants to bulge into the lumen. But for those that have an anterior, like a ceiling compression, then yes, the aortopexy would help. It's the less invasive. You can go anterior mediastinum, you can sort it out. Obviously, the posterior tracheopexy involves a thoracotomy, going back into that space. So, you either, you weigh your options. But if it is posterior, the anterior pexy won't necessarily fix your problems.
Selo, please continue.
Yes, thanks. I was wondering, is there still a role for the cricothyroidectomies instead of just going up front doing tracheostomies? Because I remember in adults, particularly with acute upper airway obstruction in casualty, you needed a quick to establish a quick airway, you would opt for that. Is there still a role, particularly in kids? Does it serve a function?
You mean a cricothyroidotomy, like a front of access?
Yes, in pediatric population.
So do you want to answer?
Well, I wouldn't advocate for that, especially in kids, because they have very, kids, everything seems to be having an overlap. The thyroid cartilage and then the cricoid cartilage there. The cricoid membrane is not as wide as you find in adults. So doing that, I mean, unless maybe you are dealing with a bigger kid, but then generally we don't really go for that or advocate that. And in doing so, it's a small space. Even if you are able to do it, the resulting complication of the chondritis or the inflammation of the cricoid cartilage will eventually lead to a subglottic narrowing in such a child. So we don't really go for it. But as you know, in medicine, there are lots of gray areas. Sometimes you may find yourself needing to save the child, so you have no option than to do it. But if you can avoid it, we would advocate that you do avoid it and go for a proper tracheostomy.
So yeah, I totally support Isaac's comment, is that there is no cricothyroid membrane that's as visible or that's palpable as it is in an adult, or at least in a younger, bigger child. But sometimes if you're saving a life and you can't get in, then you can do whatever you think is necessary. Front of neck access is advocated for those children, where you go where you think the cricoid is and you go below that. And the reason is that the larynx is anterior. So if the larynx is anterior, if you presume where the cricothyroid membrane is, you may end up hitting a vocal cord or worse. So you may not actually go in and down, you may actually go in and up or in and through to the back. So yeah, so you want to just sort of learn a bit about the front of neck access in the event that you need to do it in children. It's just safer and it's a once-off. Adults, certainly the cricothyroid is your like movie style, you go straight into the membrane, but in children it's not that easy.
Okay, thanks. And last question about the contrast you use when you're doing a tracheobronchogram. What do you use? Because we always avoid or try to avoid any kind of contrast being aspirated, but clearly with this particular investigation, you are putting it straight into the airway. So
that's under very, very rare circumstances. That's why we've recorded the video to show people. It's only in cases where we can't get any imaging, we can't risk taking the tube out. That was a child who was born with the tetralogy fellow unrepaired and was intubated and was, that tube was stuck on the stenosis. Okay. So we had no other option. So we basically get that from our radiologist and they give it to us. And we use it very, very diluted. So you can see that it's not dark. It's just something that just literally slips down. That's all it does, is it slips down. So you're giving yourself almost like a tracing. And that's all we really needed was, do we have the right diagnosis here? And are we okay? Because even to put someone, to take that tube out, you have to put them on bypass and all of that. So we just needed a diagnosis, really.
Sure. Thank you.
Thanks for your questions.
The last comment I'll ask is our senior consultant pediatric surgeon, Dr. Yashoda Manikchand. Yashoda, any comments?
Thank you for the talk. It was really good and engaging with the videos and the pictures. My question or comment would be about the acquired subglottic stenosis. I think we're seeing them a little bit more frequently than we'd like. And then Isaac was talking about how to prevent. And my take home was something that we could improve on is sedation during ventilation. But I just wanted to ask if there was a time period for prolonged ventilation where you would consider a tracheostomy, or would you just do get the ENTs to do a fiber optic scope before, after you extubate them?
I mean,
is it that you want to know how long a patient can stay intubated, or
yes.
what do we classify as prolonged intubation?
Exactly.
Depends on the cause.
Yeah, depends on the cause. And it's actually one of the indications for a tracheostomy is if you anticipate.
So the Guillain-Barré,
yes, it's going to be a prolonged intubation, then you don't even wait 5-6 days. But in some conditions where you cannot really, but maybe trauma or something where a patient can be intubated maybe just 2-3 days, this is not really an indication for a tracheostomy. So as Prof said, it depends on the cause. Yeah.
Okay.
But that part, you wanted to know if we could actually scope the patient intubated.
Yeah, if you can't, no, I mean, should you get an
Once the
ENT
tubes out.
to
Once the tubes, okay, out.
These are, I mean, what we're saying is not an exact science. So please, we say it from our own experience. So these are real questions, and so many people ask these questions, and they're so real. And we feel for you because we're lucky that we are the people who can advise. But when you're with the patient, it's hard to make the call. I would say anything over 5 days where you have in the initial period swelling and you're waiting for the swelling to go down, you wouldn't do a trachea then. If you've got an infection in the neck or something that you're treating in the neck, also again, 5 days, you'll know if you're winning or not. And if you expose anything in the neck, you don't want a trachea there. So burns, things like that. You'll know if you're winning. If somebody has burns on their neck, you can't put a trachea there if you need to graft and keep them fixed and things like that. So we take the hit for patients like that and we keep the tube for a bit longer. If they have a severe head injury and they've been sedated and you want to wake them up and you need to know if their brain is okay, then you take the hit because the sedation lightened with a tube in the airway may give them, subglottic issues. So I think it's patient selective, but certainly if you've got a reversible condition, it's under 5 days, I wouldn't worry too much. I think the main thing is, this is what we say, which is one of these soft rules, is if you extubate someone, if they have stridor and it goes away after, 48 hours, then you should be okay. But if they have ongoing stridor after you extubate them, then you need someone to see that. And I would say after, if they don't cope after 1 day and you think you need to reintubate them, you call the ENT. But if the stridor doesn't go away after 2 days, you need someone to come see them. So you base it on the symptoms after extubation.
Okay.
Short, if
Thank
it's a short.
Yeah, that was very helpful.
We can talk forever, sorry. It's one of those things.
Yeah. Yes. Okay, thanks.
Yes, usually what we do, Shazia and Isaac, is if somebody needs to be intubated beyond a week or so, then we start getting the ENTs involved. And sometimes these difficult, where we anticipate problems, we actually then extubate in presence of the ENT surgeons, so that if something needs to be done, then they are there and it can be done.
Yeah, that's fantastic. And that's, there you go, you've got your aero multidisciplinary team, aero digestive team. You've already done it. You don't need any fancy title.
Yes. Okay. I think it's very wonderful discussion that I have enjoyed. Isaac, you need to encourage your colleagues from Ghana, pediatric surgeons, to join these Zoom meetings, which happen usually on the second Tuesday of every month. And so thank you for coming to South Africa and for your talk. I think one last take-home message from Isaac.
Okay, so my take-home is just as Dr. Valeswa said, managing airway conditions, especially in children. As Prof also said, children are not just small adults. It's quite complex, and you actually need to consult the right people so that you can actually give the right option or the right help to the child, because any little thing that you do, you may think that you're helping the child, but if you don't learn and you don't ask, you end up actually causing more harm to the child than you would actually have anticipated. So I would just hope that we will be able to train more ENT, pediatric ENT airway specialists. It's unfortunate that we are few, but hopefully we can also train others, and then we can bring such trainings and webinars to also create the awareness out there, so that all of us can learn how to manage properly the airways of children. Thank you very much.
Thank you very much. What I will do is I will edit the recording of this session, and then I will upload it on my YouTube channel, and we will share it so you people can also share it amongst your ENT colleagues. the next talk will be on the first Tuesday of October. That's the 1st of October, where we are expecting a talk about achalasia of the cardia by Dr. Haitham Dagash, who is a pediatric surgeon from UK. And for the pediatric surgical colleagues, we are going to host the South African Association of Pediatric Surgeon conference from the 1st to the 4th of May at Pequeni Beach Resort near East London. There are 8 international faculty who have confirmed their presence. So the registrations will open in November. So thank you all. Thank you, Shazia, Isaac, and all those who attended and asked questions. And you have a good evening further. Thank you. Bye-bye.
Thank you very much.
Thank you very much.
Bye.
Bye. I'm sending